So I'm going to talk to you about my area of interest, which is surgical management of spine tumors. So, Jora, how are you? Doing good? All right. So, Jora, I'm going to show you this case over here. Tell me what you think, okay? So you have a 23-year-old lady. She's coming in with a 1-month history of back pain. On the day of presentation, she stood up from her desk, finds severe pain and weakness that she could not get up. She was brought to the hospital with an ambulance. On exam, she has a 4- out of 5 strengths in both of her iliopsoas. Otherwise, she's 5 out of 5. She has a sensory level at T12. Reflexes are normal. So mild weakness in her iliopsoas bilaterally. And here is her MRI. The MRI shows something going on at T9. Can you describe what you see at T9?
Yeah, so, that vertebral looks like it's potentially has a pathological fracture. And then if you're looking at the axle, you can see epidural compression, at least in the left side of the framing, some canal, and also on the right side of the framing, you surgery. So I would say compression and pathological fracture at T9.
Okay, great. So Joe was my resident at Ohio State, and he knows my style already when it comes to just call on some residents. He's okay. So just kind of like in a show of hands, you guys are looking at this case. It's a lady in her 40s. She has some mild weakness in her iliopsoas. She comes to the emergency room. That is a typical case you're going to see anywhere you go. And I'm making it easy. Then she's not having bowel and bladder incontinence. She's not weak in her legs to the point that she's almost paralyzed. She's a little weak. And that's what the MRI show. So on a show of hands, how many people here will take her to surgery from the emergency room? No fear. Nobody's. Who would take her to the emergency room based on what you see right here? Anybody? She's in a lot of pain. She has a fracture. So when you examine her, while she's lying there on a stretcher, she's 4 out of 5 strengths in her iliopsoas. When you tell her, do you want to get her out of bed and see if she ambulate?
Yeah, that's the key question. This is one of these amazing things that happens so often, is there's a substantial difference between the neurologic exam of strength to confrontational testing while lying supine on a bed. That does not mean that the patient is neurologically intact. And those two things get conflated in perpetuity. And it's actually very frustrating. But this person does not have a neurologic exam, does not have a full neurologic exam unless you have stood this patient and walked, period.
So a lot of times when we talk to the resident, the fellow, there's some what we call pain-limited exam, right? Where you say it's 4 out of 5 strengths, but it could be that they gave good strengths, but they have so much pain that they may not give you a good effort. So who wants to get her up and see if she's able to ambulate? All right. So
I don't understand. Like, we just had this conversation. Okay? This person does not have a neurologic exam until you have stood and ambulated them. So unless there is a contraindication to standing this patient up, like they have a fracture dislocation, I don't understand. You just asked the question and like 8 hands went up. Like, this person, you do not understand this person's neurology unless you have asked this person to stand and walk.
So is anybody here say, I'm not comfortable getting this patient out of bed and see if she can walk? You guys worried about the fracture? You worried about the cord compression? Is it severe cord compression, moderate cord compression, mild? What would you define it?
It's severe cord compression.
Severe cord compression, right? Nobody disagree with that. Does anybody have any issues with her getting out of bed and check her out, see if she can walk?
What do you think this woman's been doing for the last 39 years or 37 years? She's been walking.
So you get her out of bed, she gets up, and you have 4 out of 5 strengths in her iliopsoas. She feels like she's weak, she's wobbly, but she's walking. So now what? Who's taking it to surgery? Severe cold compression. You guys all say that.
Well, so now that's not necessarily somebody who has to go to the operating room immediately.
Hold on. I'm curious to know what's going to happen here. So you are the neurosurgeon, the orthopedic surgeon on call. That's the situation. Severe cold compression, 4 out of 5 strands, wobbly on her legs when she's ambulating, severe pain. Anybody ready to take her to surgery? And if yes, why? And if no, why not? Nobody want to take a chance? Jora, what do? You do this all the time, right? At OSU, at the James, every other night you get something like this shows up. Do you call the chief resident and you say, hey, Ranjit, we got this case, needs to go to the operating room? Or you're like, I'm going to call him in the morning, there's no rush.
So if she's able to walk and she only has pain on her weakness and they're pain under control, then we assess.
So you make the call, Jora, you make the call. At that moment, there's nothing emergent about this. I can wait.
Medical progression, but neurologically functional and how myelopathic.
So you're not impressed with the severe cold compression. You just say, admit her to the floor. I'm going to let the chief know in the morning.
What time is it?
It's noon. The chief is on a case, going to be there all night.
Okay, so everything that I just said has to be balanced against the following, which is that patients have this extraordinarily amazing way of showing up immediately before the proverbial, shite hits the fan. It's incredible how often that whatever it is about us, we understand when we're actually at the edge of a cliff, and it's unbelievable how often patients show up in that moment. So it's a different conversation if this is noon versus 4:15 in the morning. Those are different conversations.
Okay, go ahead.
I would just operate, decompress, remove the mass is compressing, and then based on CT beforehand, hopefully make a decision on whether or not that fracture can be accessed through transpecular approach and removed or can be provided, or if I could just fixate, or if I can just decompress alone and just get the mass out. There's quite a bit of stability in the lower thoracic cave, so I might be able to get away with just decompression and evacuate this and evaluate the fracture on CT.
Okay, at least I got one. Taking the patient to surgery right from the emergency room. Anybody else want to join? Anybody want to critique?
What if it's a radiosensitive mass?
Your colleague says, what if it's a radiosensitive mass?
Like multiple myeloma or something of nature?
Yeah.
I would send them frozen in the OR and make a decision on how to separate them.
Okay, so you say, even if it's a radiosensitive tumor, I'm not waiting to figure it out. I'm going to figure it out during surgery.
Well, there's an epidural hematoma with compression.
Yeah.
So no matter what, that needs to be.
Yeah, but that's not a bleed. That's a tumor that can melt away with radiation or chemotherapy. Hematoma will not do that, right? It will take some time.
Absolutely. I mean, the thought process is I would biopsy, as I began the case, in the first place anyway.
Yeah.
Full removal after that.
Yeah, so this is a very common statement where you are concerned about severe cold compression, and the thought process is that needs to be decompressed anyway. While I'm there, I'm going to do the biopsy, and then I'm going to know what it is. It's common. You hear it many, many times, which is exactly what you heard. So I'm asking again, what's your name? Galal. Anybody else here would do what was just mentioned? Anybody, how many would not take this patient to surgery at this point? Somebody, either you're here or you're here. You can't be on both sides. Go ahead, raise your arms. How many will not take the patient to surgery? Okay, so everybody here other than Galal, it seems like you're in a minority here. Let's see what happened here. So that's the situation. No surgeons get called. Here is the MRI, a little bit, a couple other cuts. Okay, there's a lot of cold compression. What's this stuff on the side out there? What's all that?
Tumor.
What is all that? That's tumor, right? That's not just inside the canal, it's also wrapping around the vertebral body, right? There's a CT, there's clearly a fracture there. which goes along with what Galal said, that there's a fracture there. He's worried about also instability maybe, needs to be instrumented, all that stuff. There is a fracture there. That's why she's having pain too. And this patient goes to surgery and have a laminectomy, emergently, from the emergency room. That's the post-op CT. That's what the MRI looks like after the decompression. Okay? All of that. What's that? That's still tumor, right? And you know, when you do laminectomy and you have severe compression around the spinal cord, sometimes you can see there's still a lot of tumor in the canal, but yes, you take a lot of the pressure off the cord, no question about it. And the patient is doing great, happy. The pain got better, all that stuff, because you got some decompression. And so I'm going to ask you another question. Same case, but instead of 4 out of 5 strands, she's only 2 out of 5 strands in her legs. She's not anti-gravity. She's unable to walk. Same MRI, same patient, just the exam is a different exam, it's worse. How many patients how many of you at this particular case will take the patient to surgery? Okay. How many of you guys will not take this patient to surgery? Why would you not take this patient to surgery?
I still think we need to get the information.
What kind of information are you looking for?
The CT, the pathology.
You have a CT, I just showed you the CT. You have a CT, a same patient, I'm just giving you a worse exam.
I don't think it's bad enough. I still would like pathology.
Okay, so you say she's 2 out of 5, she's barely moving her legs, but you say it's still not enough. I'm not putting you on a spot here, I'm just trying to understand. You want to know what it is what you're telling me.
Yeah, it's a young patient. What if it's a primary cancer?
Okay, so you see what's happening here, guys? Right? I mean, you see how a case can have such a huge difference. It could be a small percentage, but that's inevitably what happened in a lot of the situations where some say go, some say don't go. Whose decision is it? Yours. Nobody else, not the emergency room doctor, not anybody, is going to have to make that call for you. It's going to be you. So this case turned out to be, from the first case, turned out to be lymphoma. Anybody knows anything about lymphomas? These are hematological type cancers. How radiosensitive, chemosensitive are these tumors? Right? They are medical entity diseases. They rarely require surgery because they melt away so quickly. This patient ended up having a laminectomy, and now you can't radiate them because you have an incision, right? It takes 4 to 6 weeks to let it heal. By the time that happened, that tumor grew back from all this stuff around, and she came back not moving her legs within 6 weeks after the surgery, waiting for the radiation and everything else to start. And within 3 months, 4 months after the surgery, she actually died. So that's the scenario about this case. And that is the essence of what happened with what's going on with spine tumors. Decision-making are tough. And what I'm going to try and show you through my talk here today is that you cannot think like a spine surgeon on these cases. And I know it sounds crazy. You cannot think like this as a spine surgeon on these cases. You think first as a cancer person, then you think about it as a spine surgeon. You look at it from the oncological point of view as an oncological surgeon, and then you think about it as a spine surgeon. We are so trained constantly in everything we do, whether it's a traumatic spine, infectious spine, degenerative spine, to prevent deterioration in patient neurological status, right? It's all about the neurological status, that sometimes 4 out of 5 strands versus 2 out of 5 strands, where is the breakdown where one will say 2 out of 5 is still not, I'm not too worried about it, I still want to know what it is, versus a person who say 4 out of 5, that's enough for me to take this patient to surgery. How much of a neurological deficit are you willing to accept before you take a patient and you declare, I'm taking this patient to surgery? It's a tough decision, right? It's a tough decision. When are you going to take this patient to surgery? Because if you take these 4 out of 5 strengths patient and you put them in the ICU, like Jora is saying, I don't know what it is, and she deteriorates, and now within 3 hours she's not moving her legs, you just sat on her, waiting for whatever it is you're waiting for. If you not take a patient with 2 out of 5 strengths, you're waiting for the biopsy, and now he's paralyzed 3 hours later, why didn't you take the patient to surgery? It's tough, right? So it's up to you. Here's another case. 51-year-old, several months history of low back pain, bilateral severe leg pain, comes into the ER 1 week progressive foot weakness with bowel bladder dysfunction. Here's the MRI. Anybody want to take a shot at it? What do they see? Who's Campbell David? David Campbell? No? Elena Attar? Elena, what do you think? What do you see over there? Yeah. Canal is full, right? The canal, sacral canal is full. Does that explain the patient's symptoms of bowel bladder incontinence, foot weakness? Yes? Okay. So this has been going on for about a week, progressively getting worse. I'm asking you the same situation. What are you going to do? We don't, over the last week, start becoming, and now it's to the point where it's becoming, in the last 2 to 3 days, it's much worse. She's now incontinent, no rectal tone, incontinent. Okay. Surgery. You're taking it straight from the emergency room? Okay, you get a CT. It shows you there's some tumor at the sacrum. CT is not going to make a decision for you whether you take it to surgery or not. You're going to do a decompression. Okay. How many of you guys, same questions, how many of you guys will take this patient to surgery? Now. Why? Okay, what would you do?
So based on the CT, I'll see how much the sacrum is deteriorated or not.
Yeah. Yeah, forget about, you guys are always focusing about, you've seen so many screws and rods here, you lose the, forget about the screw, I don't care about the instrumentation. Instrumentation is the easy part. What's the purpose of the surgery? Decompression. So you say, I'm worried about the bowel bladder incontinence, I'm worried about the foot weakness, she's going to surgery to decompression. All the other stuff, L4, pelvis, mixed node, whatever. Anybody else would do it? Jora? You will not.
It's one per week. If it's a primary bone tumor, you need not one block resection for survival. Then I would.
You got trained well. You got trained well. So to explain, what's your name?
Jared.
Jared. Explain, Jared, what's your concern here? What exactly are you saying?
So if you go into laminectomy and do like a partial debulking and clear up the canal, clear up the neural elements, you'll achieve the goal of your surgery, but if you don't achieve one block resection, you're not going to.
Jared, do you have anything to say?
Yeah. So if you do a laminectomy and you clear up the central canal, you free up the neural elements, you achieve the goal of your surgery. But if, for example, it's chordoma and you need a unblocked resection, which will improve outcomes overall, you won't achieve the long-term goal.
So what Joe is saying here, listen the call that he's making. I think it's very critical. He says, I don't know what it is, but I'm willing to accept the deficits that you have described. He's willing to accept the deficits. Wait, it could become permanent, as you said, because you're worried about the neurological deficit. He's willing to wait and get a biopsy, which will take, how long does it take at Ohio State to get a biopsy result?
Few days.
Few days. Kojo? 5 days.
5 minutes.
Oh, 5 minutes at your institution?
You have 5 minutes.
Oh, I have 5 minutes. I'm not going to go. I'm not going to spend too much time here. But my essence of what I'm trying to show you is that I'm going to go to this particular case. Do you understand what he's saying? If this is a primary bone tumor, the cat is out of the bag. You have just took the only chance this patient has with an en bloc resection for a curative procedure. You took that chance away by doing the surgery. Not that you're wrong, but that is something you have to consider, right? So this patient underwent an intralesion of the bulking, just heard what you said, had a lumbopelvic fixation. This turns out to be a chondrosarcoma, a primary bone tumor. Now, it's over. This is intralesional, it's spread everywhere. They found out it was a chondrosarcoma. They ended up doing a stereotactic radiosurgery. And 6 weeks after the surgery, they did that. And guess what? Is the patient happy? Absolutely. Why? The bowel bladder function came back. The foot pain, foot weakness, all resolved because the pressure came off, right? You decompressed. For how long? 3 years. In 3 years, he come to see me after he had his surgery up north. And he says, Dr. Mendel, now I moved to Columbus, and my screw is poking up from my back, and he's pointing to this, right? He says, my construct is falling apart. It's coming out to the back. What do you think this is? This is not a screw. This is a recurrent chondrosarcoma that's already getting ready to pop like a pustule right through the skin. And look what's happening in the canal. Everywhere that you wear, filling up the entire canal, game's over. And the rods are broken, there's no fusion. So he needs a revision for the construct. You know, he ended up, you can see the rod is broken. I took him to surgery. We did an en bloc resection of the lesion, but this makes no difference now. And after that, the rods have been revised, and then you need to have this huge flap by plastic surgery to be able to close the wound. So what's the take-home point? And I'm going to stop there because the coach is going to kill me. The take-home point is that mismanagement related to bad timing operation and operation with no diagnosis. I want to just end with this last case, 66-year-old Holocaust survivor who comes in with this. And I know you have some of your orthopedic surgeons, but there are many neurosurgeons over here. And sometimes it's not extradural, it's intradural. And you can see this thing over here, and the cord is squashed. And if you look at the left picture, you can see that there's a stream of cord overlying a very large mass that's sitting up within the spinal canal. Hold on. All right, he's neurologically intact with severe cord compression from an intradural lesion. All right, he turned out that during his Holocaust time, he was experimented on and developed 3 types of cancers that he had a known cancer history for. There was a prostate cancer, there was some sort of a leukemic cancer, and there was also a multiple myeloma type cancer that he had, 3 of them, all of which he had the clean bill. He had no recurrences anywhere, and he presented with this lesion. So what do you do with something like this? The cord is being squashed. What I'm trying to show you is that, you know, when you show these, and I've showed some of these cases in our oral board exam for a lot of the candidates, there's a lot of opinions. How are you going to biopsy something like this? Are you going to do it anterior? Are you going to do it posterior? Should you do anything? Right? It's in the canal, the cord is squashed, and he's neurologically intact. We did a PET scan. The PET scan shows extremely active tumor. It means it's rapidly active tumor. This is not a meningioma. This is not a schwannoma. They just don't look like this. Something so bright. And so the thought was this could be potentially a leukemia. Have you ever heard about the term chloromas? This was a chloroma, highly radiosensitive. No diagnosis, no biopsy. You can't biopsy this easily. It's intradural. We decided to do a low dose of radiation. The radiation oncologists have the kahunas, and they said, okay, this is one of those cases where we're not going to demand a biopsy. Let's try low dose radiation. And that's what it looks like after 1 small dose of radiation, with no biopsy, no laminectomy, no anterior vertebrectomy, none of that stuff. All right? So be aware of the triple W, the wrong operation on the wrong patient by the wrong surgeon. Kojo, I'm going to stop here. All right.
I just want to make one quick comment, Dr. Mendel. This is a fantastic talk, and I think it goes
This
to
is just the beginning. Yeah, go ahead.
I also could keep on going, but for the neurosurgeons in the room, I don't have an applicable orthopedic surgeon analogy, but for spine surgeons, you're so trained in early practice on neurologic function, right? Someone comes in with a foot drop or loss of bowel bladder, and they have a disc, you take them to surgery. They have a hemorrhage or a fracture, you take them to surgery. But when it comes to spinal tumors, just like Dr. Mendel was talking about, you're thinking about it more like a neuro-oncologist. And for neurosurgeons, someone comes in with a centimeter shift from a subdural hematoma, I mean, you take them right to surgery, right? But what if they come in with a centimeter shift from a GBM, right? I mean, at that point, the radiographic appearance doesn't matter, especially when you take into account the overall picture. And in oncology, it's going to be survival. And there's a lot more treatments that have to be taken into account. That's an excellent talk.
Yeah, I think, again, it's go back to the two key points out of this is neurological exam and deficits are important, but don't think about it first as a spine surgeon. Going back, you first have to think about it as an oncology person, understanding the tumor biology, which gets back to the second point, and it is, don't find yourself operating on something that you don't know what it is. If you have the time to wait to find out what it is, wait. If you have the time to wait, get the biopsy. Is it a lymphoma that can respond well? Is it multiple myeloma that can respond well? Is it chondrosarcoma that needs a non-block resection? If you have the time to wait and you're willing to take the chance sometimes to say, I have bowel bladder incontinence and a foot drop, looks like an isolated sacral lesion, looks like a chordoma, this is a case where I'm going to wait in spite of that. It's a hard call, harder not to do the surgery and the decompression. It's much easier. Nobody's going to criticize you to do the laminectomy and the sacral lesion, and the patient's happy for 3 years. But it's over. So it's what I'm trying to show you. We can talk about a lot of stuff that's going on in spine oncology, but this is in essence what happens as you're dealing with these type of patient populations. All right, guys, thanks.